No worries. Thanks, Nick, for inviting me. So actually, just prior to you asking me to do this, I'd already met up with Samenda and Alison about updating particularly the PIMS-TS guideline in view of the fact that we're obviously starting to see some new cases, but also in the process of putting together a COVID pneumonia guideline, because we didn't really have one from the first time round. So hopefully both of those will be updated, and with a bit of luck I can get it done by the weekend. So I've got about half an hour to talk about COVID-19 pneumonia and PIMS-TS and the current sort of management guidelines. I'll talk a little bit about some of the sort of science behind it, but just a very brief overview, to be fair, because we've not really got time. So first of all, I'll talk about COVID-19 pneumonia. So I'm going to go through some of the sort of treatment options where there's evidence, some where there's limited or minimal evidence, and some where there's absolutely zero evidence whatsoever. And then at the end, just sort of give a summary of where we're at with what we're going to do for COVID-19 pneumonia. And then after that, I'll do the same sort of thing, but with PIMS-TS. So, I mean, primarily, mainstay of treatment for COVID is supportive care, as you will all be familiar. So all the things listed down here that you're all very familiar with, and what we were doing right at the very start of the pandemic before we had any evidence for any treatments at all. So respiratory support, fluid management, prevention of VTE, pain relief, prevention and treatment of secondary infection, although that's relatively uncommon, and all the other various kind of bits and pieces that we do, whether it's in A&E, on the general peds wards, or in ITU. So if we get that bit right, that's definitely the most important section. Everything on top of that is really a bonus, particularly as the evidence for any treatment beyond that is really only from adults, and there's nothing really for children. So what evidence is there? So dexamethasone you'll all be familiar with and would have heard about from the recovery trial. So this was sort of the first bit of evidence, or first treatment where there was some actual randomized control trial data. So this was the recovery trial, and you can see huge numbers of patients in this, nearly 6,000 patients. And in the top sort of left, you can see overall mortality was significantly reduced in those patients that received dexamethasone versus those that received usual care. And kind of overall, the reduction in mortality was nearly 20%. If you looked at those who were on oxygen, it was reduced by about 18%. And those with mechanical ventilation, it was reduced by up to almost 40%. Interestingly, those who weren't on oxygen at the point of randomization seemed to do slightly worse, so that didn't reach statistical significance if they received dexamethasone. This may be because the dex reduces the sort of ability to clear the virus, or doesn't suppresses the sort of immune response to reducing the viral load. So there is sort of biological plausibility for that, but still a little bit unclear. So essentially, dexamethasone from around May, June time has been recommended for patients with COVID who are needing oxygen, but is not recommended for those who don't need oxygen. The adult dose is 6 milligrams. Pediatric dose, as you can see there, 150 mics per kilo, up to a maximum of 6 milligrams, and that's essentially the same as the dosing for croup. And it's once a day for 10 days or until discharge, whichever is sooner. And there's no need to wean the steroid dose after that. You just give you 10 days and then you stop. So next medication where there's a bit of evidence is remdesivir. So this is obviously an antiviral drug produced by Gilead quite a while ago and used for a whole variety of different viral infections without really very much success. It was used during the Ebola epidemic, again without very much success. So on the left here, you can see the trial carried out by the company themselves, the ACT-2 trial, and there's pretty weak evidence that it seemed to improve outcomes in patients who were on oxygen. But, as you can see from at the bottom, if they're mechanically ventilated, absolutely no difference whatsoever. If they're on high flow or non-invasive ventilation, essentially no difference. And if they were not on oxygen, there was no difference. So it's only this really small kind of window of patients who were on oxygen, but not too much oxygen, where there seemed to be an improvement in their outcomes, and that was the sort of clinical score rather than mortality. On the right hand, and so on the back of this study, particularly the US, but the EU and other places started using it. for patients that sort of fit the criteria. And as I'll show you in a minute, St George's, the adults have been using it a fair bit. The right-hand side is the WHO Solidarity trial. So that was fairly similar to recovery. So it's a pretty pragmatic trial. It's a multinational study and is not quite so sort of, is much more pragmatic. So not, like trials often are, and particularly those run by companies. So it's much more kind of real world data. And that showed essentially no improvement in outcome with patients that receive remdesivir versus control. So that's quite a bit of debate about should it be used or not. At the moment, at George's, on the adult side, they are using it. So this is from the adult microguide, inclusion criteria. So essentially adults or children over 12 needing oxygen, proven COVID or high suspicion of index of COVID, with essentially no significant renal or hepatic abnormalities, and no more than 10 days since start of onset of symptoms, and not on mechanical ventilation. So that's sort of fairly tight window of patients needing oxygen. We've used it, I think, now on 3 patients, 3 children at George's, 2 with Down syndrome who obviously are high risk of more severe disease, and 1 patient on the ward who was almost 18, so essentially came under sort of adult criteria. We've also advised 1 patient at King's, who was a kid who'd had a bone marrow transplant and again was very high risk with a very high viral load. So used it on a few patients, but predominantly those that are at high risk. So I think, if we had a 12-year-old who needed a waft of oxygen who had a normal, no significant past medical history, we probably wouldn't be advising remdesivir. But if you've got a significant background history, then at the moment we are. And you can see the dosing on the right-hand side, and broadly it should be a maximum of 5 days. So this is pretty recent data. So this is from the REMAP-CAP trial. So this is looking at tocilizumab essentially. So interleukin-6 antagonists, so monoclonals or biologics rather. So this was put together as a sort of short systematic review on the back of the REMAP-CAP study that looked at adults with COVID and a variety of different treatments. And you can see the top 5 studies there showed essentially no difference at all between those that received tocilizumab or usual care. But the REMAP-CAP trial, which predominantly is done in ITU patients, did show a significant reduction in mortality. So on the back of that, this is just from a couple of weeks ago, really. The Department of Health put out this position statement suggesting that tocilizumab, so interleukin-6 inhibitors, should be considered for adults who fit specific criteria on ITU as sort of upfront treatment. So, along with your steroid, you also get tocilizumab plus or minus your remdesivir. So I think just in the last few days, this has come out from St George's. So this is the George's adult criteria for using tocilizumab in patients with COVID-19. So you can see the inclusion criteria is obviously adults over 18, confirmed COVID, and admission to essentially ITU needing some sort of respiratory support and starting within 24 hours. And then you kind of got the dosing and so on down there. On the left-hand side, you've got exclusion criteria. So essentially abnormal full blood count or liver function or some sort of significant underlying condition where you don't want to immunosuppress the patient would be contraindications. Obviously under 18 is on there. Now, obviously it gets a little bit tricky with the sort of 15, 16, 17-year-olds that we see on the paediatric ward, and one could certainly make a case for including them in this. And I think one of the Downs patients almost received tocilizumab, but actually their white count was too low. We haven't quite made a formal decision about how we're going to do this going forward with kids. This also has impact for the recovery trial, which at the moment has tocilizumab as sort of third line rather than right at the beginning. And one of the steering committee meetings for recovery, which I'm on tomorrow, hopefully we'll get a bit more information about how we do this. I think the Evelina yesterday was on a meeting, was suggesting they are potentially going to be using tocilizumab up front in kids. They'd mentioned they'd done it at a 10-year-old a couple of days ago. Other places I've spoken to are being a bit more reticent, saying, well, this is adult data, it's not children. So if we're going down the tocilizumab route, we should try and put them into recovery trial and do it in that way. So I think this probably requires a little bit more discussion going forward about how exactly we're going to play this. Other monoclonal, so baricitinib has just been looked at in adult patients. This is similarly another IL-6 antagonist, but also has other immunomodulatory effects. And this was a trial done across various sites across Europe and the US, and was done in patients who'd also received remdesivir. So they showed fairly limited improvement, but the team felt the fact on the back of they also had remdesivir that this was sort of fairly significant. And so there is a plan to take that forward. And I believe baricitinib will be included in recovery in the next iteration. It's certainly not a monoclonal or a immunomodulator we've used yet. Then convalescent plasma, obviously that was the sort of great hope that give a boost of antibody and that will help, but actually recovery as of a few days ago has now closed recruitment, and I mean all they've put out is a sort of press release, but you can see from here mortality was 18% in the convalescent plasma group versus 18% in the usual care group. So essentially no improvement, so they've pulled that out of recovery and are no longer using it. So essentially convalescent plasma doesn't seem to provide any benefit, certainly in all the looking at all the patients. There may be some benefit in some subgroups, but they've not given any information on that as yet. And then just to sort of recap the medications that have been looked at previously and found not to be useful or efficacious. So the right hand side, I've just pulled these graphs from the WHO Solidarity trial. So hydroxychloroquine, no difference. Lopinavir, ritonavir, no difference. Interferon, no difference. So none of those should be used. And then the zithromycin is obviously the other one that's on the left side from recovery. Again, absolutely no difference. So we shouldn't be prescribing any of these for COVID-19. So next thing that's sort of quite pertinent, so thromboprophylaxis. So nice guideline that came out fairly recently recommends all adults over 16 should receive thromboprophylaxis who have got COVID-19. Obviously children, that's a little bit trickier. So particularly the smaller kids, we wouldn't routinely start on prophylaxis, but I think it's something we should certainly be thinking about. And sort of as I put at the bottom there, if you've got a 5-year-old who's otherwise fit and well and is mobile, needs a bit of oxygen, we're probably not going to start them on dalteparin. Conversely, if you've got a overweight 15-year-old, we probably will do. So I'll come on to a bit in the PIMS-TS section, and we'll probably follow similar kind of guidance for that, which broadly speaking says if you're over 5, we'll suggest some sort of thromboprophylaxis. Under 5, not, unless there is sort of some specific or unusual circumstances. So sort of summarize the COVID-19 pneumonia section. So supportive care is clearly key. If patients are needing oxygen, then dexamethasone essentially is now standard of care. I think we would consider remdesivir. That should be in discussion with the PEDS ID team and PICU if the patient is on PICU. Tocilizumab, the jury's still out a little bit. If they're hyperinflamed or on PICU, then I think we need a discussion about that. Ideally, we'd like to put them in recovery, but that obviously may not be possible. I think thromboprophylaxis probably for most children who are going down the treatment route is appropriate, but maybe not the very youngest end. And then just in terms of follow-up, not all kids will need routine follow-up if they've had COVID pneumonia. Obviously, those at the more severe end of the spectrum may well do. And I'll just grade out at the bottom there medication that shouldn't be used as they're not efficacious. And then just as a little reminder about recovery, so this is the front page from yesterday, so just shy of 29,000 patients, which probably by today is more than 29,000. I think pediatrics have recruited somewhere around 100, 120 patients, so obviously much smaller numbers as you would anticipate. And this is the current trial design for pneumonia. So children are not eligible for the colchicine arm and are not eligible for the aspirin arm. So that only means they've got the sort of middle there, which now convalescent plasma is out, is either usual care or the Regeneron cocktail of 2 monoclonal antibodies. So one patient we've recruited went down that arm and actually got usual care rather than the antibody. And then if the patient deteriorates or isn't improving, you can then go on to second randomization, which is tocilizumab or, again, standard of care. And it's worth highlighting this is a very pragmatic trial. So patients that don't receive one of the arms of treatment potentially can receive the other one. So tocilizumab, for example, if they're getting worse, they get randomized to no additional treatment. A clinician can still make the clinical judgment they think they need tocilizumab or another monoclonal, and still give that. So unlike most other trials, which are very sort of rigid in what you can do, this is a very, very pragmatic trial, and that obviously will throw up some difficulties at the end when analysing it, but does make it easier to recruit to. And this is from the paediatric kind of frequently asked questions and advice bits on the recovery website, and essentially more or less says the same thing. Okay, so I think I'll just go through everything and then we can ask questions at the end if that's all right. I can't see the chat either, unfortunately. Okay, so next up, PIMS-TS. So let's go through those background very briefly. So at the end of April, the PIC Society put out this sort of statement of an increased number of cases of kids with multi-system inflammatory disease. Fairly shortly after that, the Evelina published their short report of 8 cases of children with what subsequently is described as PIMS-TS. Then a variety of societies put out sort of definition. The RCPCH was the first one, is the one in the middle, which is the most sort of woolly, if you like, and as much as pretty much any child that presents to A&E, you can shoehorn into that diagnosis, into that criteria. The CDC's a bit more sort of objective, and the WHO one, which I think was the most recent one, is probably got the tightest kind of description of all. But as you will all be aware, as I'm sure you've all seen kids in A&E, you can, lots of kids with fairly benign pediatric infections or illnesses you can potentially fit them into the PIMS-TS criteria. There's now a few sort of diagnostic pathways. This is from the American College of Rheumatology, but it still throws up that sort of logistical issue. So on the right hand side, you've worked out this patient might have PIMS-TS, and then it has a sort of tiered approach where you do a set of bloods and then look at what the CRP and the full blood count is like. And if that's still suggestive, then I'm going to do another blood test for other sort of markers such as troponin and procalcitonin and so on and so forth. But of course, in the real world, nobody's going to do one blood test and then half an hour later do another blood test. So you end up doing all the blood tests at once. And that's on several occasions thrown up the issue of what do you do with someone who's got an isolated high D dimer or BNP or fibrinogen in the context of someone who you don't actually think has got PIMS-TS, because we don't normally test D dimers in someone who's got a UTI. So that throws up some sort of diagnostic challenges. What about the sort of epidemiology of PIMS-TS? So on the left is data from ISARIC. So this was during the first wave in the UK, and you can see at the sort of peak there was around 10 to 15 cases a week reported across the country. I haven't seen any more recent data. Maybe Shamez at the end might know some more, but I haven't seen any more recent data. The CDC keeps a kind of rolling count. So this is US data up to just after Christmas. And with each of their peaks seems to be slightly less cases, but still averaging about 5 a day. It'd be interesting to see where that goes. This is some data published by various of the UK kind of big centres. So 58 cases with PIMS-TS, and I won't dwell on this too long, but you can see Black, Asian, and ethnic minority children were at high risk. Boys were at high risk. Average age was around 9 or 10 years, and the symptoms are gastrointestinal symptoms predominantly, but also other symptoms sort of suggestive of toxic shock or Kawasaki, so conjunctival changes, mucous membrane changes, etc., etc. In this cohort, around 3/4 got IVIG, about 2/3 got corticosteroids, and a handful got biologics. Interestingly, only 14% had aneurysms with a Z-score of more than 2, and one child unfortunately passed away. The vast majority had some evidence of SARS-CoV-2, either an antibody positive or a PCR at the time, so that's about 80%. And then in terms of lab results, again, I'm not going to go through all these, but broadly, all the markers of infection, inflammation tend to be worse in PIMS-TS compared to those with Kawasaki or even Kawasaki shock or toxic shock syndrome. So you can see slightly higher white count, neutrophil count, low lymphocyte count, which is somewhat typical for COVID, lower hemoglobin, platelets, higher CRP, lower albumin, higher ferritin, higher troponin, and higher D-dimer. So, you know, very inflammatory picture. So in the summer, there was a national consensus management pathway put together using a Delphi process. So essentially that's getting a whole group of so-called experts together and filling in a variety of sort of questions around what their management plan would be. So for example, you ask what blood tests would you do, or which of these blood tests would you do? So would you do a full blood count, yes or no? And, you know, would you do this? Is this a strong recommendation, a moderate recommendation, so on and so forth? And then you do that several times, then you come together with your overall management plan. So there's not evidence-based at all. This is purely expert opinion. And I was part of I think there were 100 people involved from a variety of different pediatric specialties. And it took about 3 hours to go through one of these things each time. So quite time consuming, but does give us a little bit of guidance, albeit not really evidence-based. So this is the initial investigations, which is quite waffly, but essentially can be cut down to some blood tests, which are on our guideline, an ECG, an X-ray, echo, and then other imaging based on the clinical picture, essentially. This is even more confusing. So this is the management process. So that summarizes actually to this. So supportive care obviously is critical, much like respiratory COVID. Low dose aspirin is advised for all kids with PIMS-TS. Thromboprophylaxis similarly is advised for essentially all patients. And then scrolling through first, second, and third line treatment, IVIG, methylpred with gastroprotection, and then biologics, which broadly should be done within the context of a multidisciplinary team. So just a little bit of time on thromboprophylaxis, because it's usually something that paediatricians aren't that familiar with, unlike adults where almost every hospitalized adult gets thromboprophylaxis. So some exclusion criteria here. If any of the patients fit the exclusion criteria, then this should be discussed with hematology, but I think this is fairly unusual. If they're being admitted to the pediatric ward, then we should be using standard dose thromboprophylaxis. So you can see the various doses of dalteparin based on age and weight, and this is all in the guideline already. If they're being admitted to PICU, then we're advising enhanced thromboprophylaxis, which is slightly bigger doses essentially. Similarly is already in the guideline. And they should continue prophylaxis while they're still an inpatient. Most patients probably should stop before they go home. If there have been children who've either had a particularly stormy course or have got ongoing risk factors, that means they're not going to be as mobile or more likely to develop a clot, then consideration should be given to continuing thromboprophylaxis at home. And we did do that, I think, on one patient during the first wave, and this would be the sort of patient to discuss with hematology. In terms of follow-up, currently all our cases are, once they've been discharged, are being followed up by the cardiologists at the Evelina, because we don't have capacity to do that at George's at the moment. And all these cases should continue the aspirin, much like Kawasaki disease, so low dose aspirin for 6 weeks, or at least until they're seen at the Evelina. So just to sort of summarize all that, so supportive care obviously is critical. Right at the beginning, whilst you're working out the diagnosis, antibiotics are also advised. You should try and offer patients recruitment to recovery where at all possible, and then all patients should receive low dose aspirin and the vast majority thromboprophylaxis. And then, as I've said before, IVIG, based on ideal body weight. So that's the same dosing as Kawasaki disease. Methylpred, which we're going with a dose of 10 milligrams per kilo. The Delphi said 10 to 30, but I think most places are going with the lower end of the dose. The US, interestingly, use 1 to 2 milligrams, so quite a bit lower. If you're only giving for 3 days, there's no need to wean steroid afterwards. We did, for the first few patients, as the Evelina were, weaned off the steroid, much like with Kawasaki, over a couple of weeks. But actually, the feeling is with PIMS-TS, we don't need to do that. So you get your 3 days, or in occasional patients that are very bad, you might give 5 days, but then you just stop at that point. So there's no need to wean. And then biologics would be an MDT discussion, and we would discuss that with the Evelina, with the rheumatologists and the team over there, as they're much more familiar with biologics than we are, broadly speaking. The Evelina have a MDT once a day at 11 a.m, which we are able to dial into if there's a particular patient we wanted to discuss. And then, as I said, currently all of our cases should be followed up as an outpatient at the Evelina. So this is sort of the summary that's in microguide at the moment. As I said, I'm in the process of updating this, so it will probably change what it looks like a little bit. Broadly, actually, what it suggests on there won't change very much. One thing I will change a little bit is the sort of orange and red box at the end on the management. At the moment, it's sort of quite woolly, a lot of consider this and consider that and discuss with these people. So I'm going to tighten that up a little bit based on the Delphi and our sort of previous experience, to be a bit more objective about when to give IVIG and steroids and anticoagulation and so forth. But broadly speaking, nothing is sort of dramatically will be changing. As I said, the full guideline is on the PICU website, and that similarly will be updated, and the short version is on microguide. Again, just to reiterate, clinical trials. So on the right, Diamonds is looking at taking bloods from patients with any inflammatory or febrile condition. We're looking at transcriptomics led by Imperial. And we've recruited a handful of patients to that so far, quite a few adults as well. Recovery, obviously, we should be trying to recruit patients into that if at all possible. And then genomics is run through PICU, and that's genetics of mortality in critical care. This is from Recovery. So there's the sort of frequently asked questions and pediatric sort of how-to guide on the Recovery website. So whatever scenario you come up with, whether it's respiratory COVID or some degree of PIMS-TS from moderate through to severe, you can work out how you can put them into the Recovery trial. And much like for the respiratory one, there's a sort of flow chart. So even if they've had IV or methylpred, they can still go into Recovery. If they've had IVIG and methylpred, they can still go into Recovery. So again, the nature of it being very pragmatic means almost whatever treatment you've given them, they potentially can still go into Recovery. And the feeling was probably, if we do go with tocilizumab being given up front for some patients, that you could just put that as a concomitant medicine, still put them into Recovery to work out whether they need IVIG or methylpred, but we'll need a bit of a discussion. So I think that's basically my half hour, I think. So I will stop there, and happy to take any questions.